Clinical Medicine 1, HEENT Module, Ears 1, Part 3. Here are the objectives for this lecture. In regards to otitis externa, students are expected to demonstrate understanding of presentation, diagnosis, treatment, complication, and prevention. Otitis externa is an auditory canal disorder as part of the acquired outer ear disorders. Otitis externa, or OE, is a diffuse inflammation of the external ear canal due to disruption of skin-cerumen barrier in the external auditory canal. Key features include painful erythema and edema of the ear canal skin, often with purulent exudate, and may evolve into osteomyelitis of the skull base, which is called malignant otitis externa. I'll be talking about this a little later. Types of otitis externa include acute and chronic, but you can also have localized and malignant. Acute is usually due to bacterial infection. Most common is Pseudomonas aeruginosa. Chronic is 3 or more months of otitis externa, usually fungal or allergic in origin, may be manifestation of dermatitis such as psoriasis or eczema. May be due to inadequate treatment of the acute form as well. Localized due to folliculitis or furuncle in the external ear canal. And let me tell you a little bit about what folliculitis and furuncle are. Folliculitis is a common skin condition in which the hair follicles become inflamed. A furuncle is also a boil. It's a painful nodule formed in the skin by circumscribed inflammation of the dermis and subcutaneous tissue. Again, malignant otitis externa is an aggressive infection of the external auditory canal in deep periauricular tissues, which can lead to osteomyelitis. So who is most affected? Children age 7 to 12 years are most common, and incidence declines at age 50. There are about 2 to 4 million visits to the ambulatory care centers, or ER, per year. Now, I've been asked about how much you need to memorize from these numbers. You do not need to know that 2 to 4 million visits. Just recognize that there's a lot of visits to either an ambulatory care center, such as urgent care, or the ER. Lifetime incidence is up to 10%. Which, as you know, means that out of 100 people, 10 of those people will have had or will have otitis externa. So causes of otitis externa. Moisture, swimming, as you saw in the previous slide, there's a little boy in the pool, perspiration, high humidity. So consider this when you have, perhaps in the summertime, a lot of children are in swimming pools, or maybe they went to Florida for vacation and they come back and they have a really painful ear. Water contaminated with bacteria, so swimming in a pond, high environmental temperatures, mechanical removal of cerumen. We talked about this as a complication of cerumen impaction removal. Insertion of foreign objects such as cotton swabs, fingernails, hearing aids, earplugs, other trauma to the ear canal, and chronic dermatologic disease, eczema, psoriasis, seborrheic dermatitis, which is dandruff, and acne. Chief presenting concerns include otalgia, pruritus, erythema, edema, conductive hearing loss, jaw pain, sensation of canal fullness, oral discharge or otorrhea, and normal to low-grade temperature. History of present illness. The onset usually occurs over a few days, about 48 hours or so, to a week. Initially, it is characterized by small amounts of odorless secretion, mild comfort, pruritus, and erythema. At the moderate stage, you have increased erythema and edema, especially in the thicker lateral canal, and seropurulent secretions. Pain exacerbated by the tragal pressure or auricular movement. At the severe stage, intense pain, obstruction of the canal lumen. Extracanal signs are likely, such as auricular cellulitis, parotitis, which is inflammation of the parotid gland, and adenopathy. Complications of otitis externa include ear canal narrowing due to that edema, which will cause conductive hearing loss, extracanicular dissemination of the infection. So you have the infection moves into the auricle, cellulitis causes chondritis, parotitis, and adenopathy. Opportunistic bacterial or fungal infection may complicate chronic otitis externa. Fungal involvement is uncommon in primary otitis externa, so it's more common in chronic otitis externa. Progression to malignant otitis externa is also a complication, which is that osteomyelitis. Treatment includes analgesic treatment based on severity of pain. So for mild to moderate pain, an oral acetaminophen or an NSAID will be appropriate. However, if it's severe pain, they may need an opioid. Generally, antibiotic drops or antifungals are indicated. Antibiotics is the abbreviation ABX, and GTTS is for drops. Cipro-HC and corticosporin are two good medications that work pretty well. There's no good evidence that one medication is better than the other. We may also use medication with a steroid, which may help resolve the symptoms faster. Consider adding systemic antibiotics if the surrounding soft tissues are involved, such as the auricle, the mastoid, or if they have adenopathy. Also consider systemic antibiotics if the patient is immunocompromised, such as having diabetes, HIV, or if they're on steroids for a rheumatologic condition. If the patient is not responding to the medication, you may wish to culture the infection to see what medication may work in this case. In a non-intact tympanic membrane, which can be with tubes or with a perforated tympanic membrane, you want to use a non-ototoxic topical. Fluoxin and Ciprodex are the only medications that are FDA approved for perforated TM. So if you suspect even a perforated TM, and that can be difficult if they have a lot of swelling, you definitely want to use either Fluoxin or Ciprodex. So advice for the patient, you want to have them resist manipulating the ear. Sometimes they want to pull on it to see, well, does it still hurt? Abstain from water sports for 7 to 10 days during treatment. Now this is where you'll see variable recommendations. Some are a little bit more stringent than others. We're going by the current recommendation of current diagnosis and medical treatment. So swimming in a pool may be allowable in mild cases, but you want to avoid prolonged submersion. Competitive swimmers can participate 2 to 3 days after treatment or after the pain is relieved if they use well-fitting earplugs. You want to limit the use of earphones and hearing aids until after the pain and discharge have cleared. Follow-up is at least once Consider at least one follow-up visit to verify resolution and clear remaining debris from the canal for all but the really mild cases. If the patient fails to respond to initial therapeutic option within 48 to 72 hours, you want to reassess the patient and confirm the diagnosis of acute otitis externa and rule out any other causes. If a wick is placed, and you'll learn about wicks in clinical applications, you want the patient to return 2 to 3 days for removal of that wick. So how do you prevent otitis externa? So here's some prophylactic agents. You can use acidifying drops before or after swimming, at bedtime, or all 3 times. 2.75 boric acid or 90 to 95% isopropyl alcohol for prophylaxis after swimming. And there are some non-prescription products that contain alcohol and anhydrous glycerin. So there are some over-the-counter medications that they can use to prevent otitis externa. Potential non-pharmacologic prevention strategies: limit water accumulation and moisture retention in the external auditory canal, maintain a healthy skin barrier, remove obstructing cerumen, use earplugs while swimming, and avoid trauma such as use of cotton swabs. There's no randomized trials to compare efficiency of different strategies to prevent otitis externa, such as use of alcoholic medications or anhydrous medications. And you have to be careful because some of these acidifying drops and the glycerol can be more irritating to the skin. So patient advice. Now I have this image because you can use a blow dryer in the ear, but make sure it's relatively far away and it's not at high power and turned all the way up. But some people have been able to clear up the ear slightly by using a blow dryer for those who frequently get otitis externa. Chronic forms may have lichenification of the skin of the external canal. Lichenification is a thickening of the skin due to chronic irritation. And fungal infection is more common in otitis externa chronic form, and that's a white cotton-like strand or multiple strands in the canal. May or may not have white or black fungal balls. So if you look on the left lower, you'll see those strands with the little tips on the end, those hyphae, and in the middle, kind of that black and white. And then over on the right, it's kind of a fuzzy appearance, so it kind of looks like fungus, or it looks like, moss, if you will. Prognosis. Symptoms generally improve in acute otitis media within 48 to 72 hours of initiation of treatment. Mortality rate for malignant otitis externa is 10 to 20%. So malignant otitis externa, MEO. I know you've been dying to talk about this, so I left this at the end. This is an invasive infection of external auditory canal and skull base, typically due to, almost universally, I know this is going to be a big surprise, wait for it, Pseudomonas aeruginosa. I know, right? Surprising. Other names include malignant external otitis, malignant otitis, necrotizing external otitis, necrotizing otitis externa. You get the point. All of these things are the same thing. Most often initiated by self-inflicted or iatrogenic trauma to the external auditory canal. And in case you're not familiar with the word iatrogenic, that means inflicted by a healthcare provider. Oh, I guess an example would be if I were treating someone and I slipped and cut them. Honestly, I'm a good provider, I wouldn't just do that, but that would be an iatrogenic trauma. Incidence and prevalence, this is pretty rare complication of otitis externa. So this is really involving the temporal and adjacent bones. It's myelitis, so it's destroying the bones in the bone base there. And as I know you've discussed earlier, happens primarily in immunocompromised people, especially older patients with diabetes, and often initiated by self-inflicted or iatrogenic trauma. Typical symptoms: severe otalgia that worsens at night, otorrhea, so again you have ear drainage, unresponsive to topical agents, headache, which may be intractable meaning that it doesn't go away despite treatment. Pain often extending to temporal mandibular joint, TMJ, exacerbated by chewing. Fever over 102.2 degrees or 39 degrees Celsius. By the way, in PANTS and PAN-RE and my exams, I will give you both Fahrenheit and Celsius. Patients may be afebrile also with malignant otitis externa, especially in older patients and diabetes. Older patients often will present with no fever despite illness, and they may have swelling of the auricle. You want to ask about a history of otitis externa, oral irrigation with water for an impacted cerumen, diabetes or conditions associated with immunocompromise. And again, occurs primarily in immunocompromised patients, especially like an elderly patient with diabetes. So, malignant external otitis, the clinical diagnosis is severe otitis with intractable otalgia plus or minus a headache. So they can't get rid of that pain and tenderness near the mastoid, and persistent otorrhea. So in patients with other presentations such as facial or cranial nerve palsy. Those two are pretty bad because this carries a poor prognosis. Intracranial complications are the most frequent cause of death in patients with malignant external otitis. Okay, so this is quite a busy slide. Here's what I want you to know about it. From this slide, it's important to remember that imaging studies for malignant otitis include technetium bone scanning and gallium scans. Both are sensitive, not specific. Okay? And these are nuclear scans. So this is another relatively busy slide. CT and MRI are looking more for soft tissue and abscess formation. CT can be useful for bone erosion. MRI has poor bone resolution. CT does not diagnose early osteomyelitis, however. It has to have a 30 to 50% bone destruction to even see it. MRI, if you're worried more about intracranial complications, you can use that. So what I want you to know about this is CT, MRI, evaluation of the anatomic extent of soft tissue inflammation, abscess, intracranial complications. Neither test can be used to determine osteomyelitis resolution. Okay? And recognize that MRI and CT are equally sensitive in detecting soft tissue extent of the disease. This lower image is an axial CT demonstrating the previous mastoidectomy cavity at the arrow. I will not show you images such as CT or MRI and expect you to recognize and make diagnoses based on this. Treatment includes daily debridement of the external auditory canal. So every day, that tissue and the granulation needs to exudate, needs to be removed. Empirical IV antibiotics for high clinical suspicion. So if you suspect the patient has this, you want to give them IV antibiotics. Empirical is because you're suspecting it. Anti-pseudomonal drugs, fluoroquinolones, cephalosporins, penicillins. Antifungal if you suspect fungal to be the underlying case. And you want a control of underlying disorders as well. Keep in check the diabetes or any immunosuppression. Surgery is rarely Complications. Potential invasion or involvement of the inner or middle ear, the cartilage, the brain, soft tissue, parotid gland, paranasal sinuses, and the cranial nerves, 9, which is glossopharyngeal, 10, which is vagal, and the spinal accessory nerves, 11. So this is the conclusion of HEENT Module Ears 1, Part 3. Thank you.